Hello, and welcome to today's webinar, Psoriasis, What to Know Head to Toe. My name is Bev Bromfield, Patient Education Programs Manager here at NPF. I'd like to introduce you to our guest moderator for today's webinar, Emily Plumley. Emily is a managing consultant with Guidehouse State and Local Government Practice, where she advises governments on organizational strategy, operations, and policy analysis with a focus on public health and service delivery. Emily earned a Master of Public Health from Yale University and a Bachelor in Science from the University of Michigan. While living with psoriasis and psoriatic arthritis, Emily is driven to use her experiences to improve the lives of those affected by psoriatic disease and advocate for a cure. She is also a volunteer for the National Psoriasis Foundation, serving as an advocate for the Central Advocacy Committee. Thank you, Emily, for being here today.
Thanks, Bev. Hi, everyone. We appreciate you being here with us today. Before we start, I'd just like to go over a few items so that you know how to participate in today's event. So you should see a panel that looks like this on your computer desktop. You've joined this presentation using your computer's audio system by default. So this means if you hear music through your computer, you should be able to hear the presentation. You will have the opportunity to submit questions to today's presenter by typing into the questions panel in the circle. Click on the questions at the top panel, type your questions in the panel that pops up on the right, and then post. We've also received questions in advance of today's webinar that we'll try to address as many as possible during the Q&A session with our speaker, Dr. James Song. And I'd like to take one moment to acknowledge and thank our Psoriasis Action Month sponsors, CeraVe and Novartis, for their support of today's webinar. Thank you. Before we start, just a few words about what the National Psoriasis Foundation does. At the heart of all we do is our mission to drive efforts to cure psoriatic disease and to improve the lives of those affected. And we accomplish our mission by funding research with over $30 million awarded in grants and fellowships, collaborative and transformational research initiatives. The NPF also offers education for those living with psoriatic disease and encourages all to become involved with our mission. And you can learn more about our research, education, and how you can become involved by viewing the links listed on this slide. On behalf of the National Psoriasis Foundation, thank you for attending today's webinar, Psoriasis, What to Know Head to Toe. And now I'd like to introduce you to our speaker, Dr. James Song. Dr. Song is the Director of Clinical Research at Frontier Dermatology Partners, where he is actively involved in the development of new therapies for many dermatologic diseases, which offers firsthand experience with treatments before they come to market. As a board-certified dermatologist, Dr. Song has a special interest in medical dermatology, treating diseases such as psoriasis, atopic dermatitis or eczema, alopecia, and more. Dr. Song is also a clinical instructor at the University of Washington and is active in teaching medical students and resident physicians. He's been published extensively in peer-reviewed journals and regularly participates in meetings as both a lecturer and attendee, staying up to date on the latest advances in dermatology, some of which you'll hear about today. Dr. Song believes that the best health outcomes come from shared decision-making between patients, such as all of you and the physician. And he strives to help his patients understand not only their disease, but also what their treatment options are, which helps them make decisions they can feel comfortable with. It's my honor to welcome Dr. James Song for today's webinar. Please welcome Dr. Song.
Thank you, Emily, for that kind introduction. And thank you to all of you who are joining us for today's program. And as already been said, thank you for sending your questions in advance. I'm going to try to address as many as I can, but as you can imagine, with the limited amount of time that we have and the nature of some of these questions, I could only address some of them, but I promise we're going to at least try to speak in some generalities that could at least, hopefully you find it helpful. So with that, we'll get started here. This next slide here is going to be my disclosures. I am a speaker, consultant, or an investigator for several of the companies that make products for psoriasis. And the objectives for today is that we'll first talk about treatment options for psoriasis that could occur really on any part of the body, whether that's the scalp, the body, the sensitive areas, sometimes referred to as the inverse psoriasis, nails, hands, and feet. We're also going to talk about why it's important to have established treat to target goals. And then lastly, the impact of comorbidities that could have not only one's health, but how that also influences the treatments that we pick in treating psoriasis. Now, when we think about psoriasis, this is a typical patient that I think comes to mind. You have these well circumscribed pink plaques with those very characteristic silvery scales in the classic locations like the extensor surfaces. But it's important to recognize that psoriasis could appear elsewhere, sometimes on the scalp, sometimes on the face, underneath the breast, we call that inverse psoriasis, and the nails, sometimes together, sometimes in isolation, and even the palms and soles. And what I want to point out here is that these, what we call special site areas, they can coexist with our typical psoriasis plaques like you're seeing in boxes A and B, but they can also exist by themselves. And if you're seeing a dermatologist or a provider that's not experienced in psoriasis, this could lead to some diagnostic uncertainty. Not only that, there are certain treatment nuances when we're treating different parts of the body. For example, I cannot give someone the same treatment for the scalp or the palm, the soles, that I would be giving someone on the face or in the underneath the breast. And lastly, and this is perhaps the most important point, it's that it's not just body surface area that matters when we're assessing severity. It's the site, it's the location, right? So patients who have limited body surface area, but they have some of these special sites that are involved, they could have a profoundly negative impact on their quality of life. And so we need to be aware of that because those patients deserve just as aggressive treatment as patients who have more extensive body surface area. This is the traditional way of how we assess psoriasis severity. We went by what we call the palm print rule, where one palm print from the heel of the palm to the tip is 1% body surface area. Okay, and if you had less than 3 palm prints, we call that mild. If it's 3 to 10, that's moderate, and more than 10 would be considered severe. Okay, but you have to understand this classification was really meant for clinical trials so that we as researchers, we can make sure we're speaking the same language and that we're studying the same patient population. But what has happened is that clinicians and ultimately insurance companies, they've adopted this as their way of assessing severity, and oftentimes they've limited patients from getting access to some of these biologic or oral therapies, right? Unless you had greater than 10% body surface area. But as I just showed you, you can get psoriasis in these special site areas that are far less than 10%, and it can still have a very profound impact on quality of life. And those are the patients that have been historically undertreated because of this classification scheme or the limitations of it. And so this is a recent publication actually from the National Psoriasis Foundation showing that not all types of psoriasis are created equal. And here we're looking at how the presence of special site psoriasis could affect quality of life. And so this included over 4,000 patients. Roughly 80% had a special site area. And what they found was that anywhere from a third to just over 70% of patients who had less than 10% body surface area, so that would be considered mild or moderate based on that definition that I just showed you, they still reported moderate to extremely large effects on their quality of life. This is a different study that was also published recently, but similar objectives. It's called the Uplift Survey. And what they looked at was over 3,600 patients that were surveyed, and roughly, again, about 80% of patients who documented or reported a special site area involved. And what they found was that if you had more than one special site area involved, irrespective of body surface area, you are more likely to report that your psoriasis had at least a moderate impact on your quality of life, and that you are more likely to have a positive depression screen. So again, it's not just a body surface area that matters, it's the location. This diagram comes from that same paper that I just showed you, but now we're breaking each region out separately based on where your psoriasis was affecting, and we're looking at the quality of life impairments from the psoriasis in those respective areas. And I want you to start from all the way to the right. So those are psoriasis patients who have just plaque psoriasis without any special site involvement. And we're seeing just under half of those patients reported that their psoriasis had a moderate impact on their quality of life. But as you move to the left and you're starting to get into the special site areas, you're seeing that number go higher and higher. And if you go all the way to the left, now we're seeing that 70+% of patients who had facial psoriasis, so that it had a moderate impact on quality of life. And I could take that one step further. If you were to look at the red bars, we're showing that over 50% of patients reported that facial psoriasis had either a very large or an extremely large effect on their quality of life. This is a patient of mine that just has psoriasis on his face. So technically, this patient has less than 3% body surface area because most people's faces are less than 3 palm prints. But try telling this patient that he has mild psoriasis. Okay? This patient was severely depressed, could not find a job, was not dating. Okay, and this patient failed a number of different topical therapies because that's all he received from his previous dermatologist because they told him that he had too limited body surface area. But as we just saw, psoriasis severity is more than just the body surface area. So to address that limitation, we now actually have new recommendations from the International Psoriasis Council, which is a group of experts in psoriasis. And what they have acknowledged is that there are major limitations to our current classification scheme of mild, moderate, and severe. And to address those limitations, they propose a new classification scheme of rather than going mild, moderate, and severe, we're going to just simply say you're a candidate for topical therapies or systemic therapies. That's it. And in order for you to be a candidate for systemic therapy, you need to have one of the following. So greater than 10% body surface area, which is in line with what we saw with the older classification scheme. But now if you have involvement of any special site, right? Scalp, palms and soles, the genital skin, face or nails, if that qualifies you for a systemic agent, irrespective of body surface area, or if you simply just failed a topical therapy. And what this new classification scheme allows us to do now as dermatologists, that we can start the conversation of systemic therapies much earlier than we have in the past. And so if you, as a patient with psoriasis, has special site psoriasis, but your dermatologist or your provider refuses to do more than just a topical, but that's what you want, is to escalate to systemic therapy, I would encourage you that you reference this article, right? Or give it to your provider. And if they still don't want to do it, then maybe it's time to look for another person that is willing to be more aggressive with their treatment. Now, this is the first special site psoriasis that I'm going to talk about. This is scalp psoriasis. Most common type of special site involvement. Over 50% of patients with psoriasis will report this. High impact on quality of life, especially the itch. And so in medical school, we're taught that eczema itches, psoriasis does not, but that is not the case at all, right? Psoriasis can absolutely itch, especially when it comes to the scalp. And the problem is that the more you scratch the psoriasis, the worse it gets because trauma to the skin can induce more psoriasis. We call that the Kevner phenomenon. In the same way that you could get psoriasis in areas of injury or even surgery, psoriasis sometimes appears along those incision sites. So that's just something that you need to be aware of. Now, if you're going to use a topical for scalp psoriasis, vehicle is very, very important. It matters because I can't be giving someone with long hair a greasy ointment or cream, right? Because that's going to mess up their hair. So I'm usually reaching for more like foams or sprays or oils. But the problem there is that these are often very expensive and a lot of insurance companies don't want to pay for these type of vehicles, but those are better than just creams and ointments. Now, also, there are some special considerations in patients who have afro-textured hair. For example, I can't expect a patient to use a medicated shampoo daily if they only wash their hair once a week, or if they use, let's say, heat to straighten their hair. I can't be prescribing them a vehicle where there's a high water component to it because that could undo some of that relaxing. So we need to be sensitive to that as well. Now, if that all else fails, or it's just not feasible to be using a topical to a large part of the scalp, this is when we have the conversation about systemic therapies. And oftentimes I am bringing this pretty early on to the conversation if I know that the scalp psoriasis is too extensive, where no amount of topical is going to actually work. Okay. And what we also know is that just simply having psoriasis can increase one's risk of having psoriatic arthritis up to 4 times in people who don't have the scalp psoriasis. So someone that has scalp psoriasis, one of the first things I kind of reflexively do is I'll ask them, do you have joint symptoms? Do you have morning stiffness? And go through my checklist of those psoriatic arthritis questions. Now, I also have here some images of other kind of tricks that we can do for patients that maybe don't want to go to a systemic therapy, but the topicals aren't working. So intralesional steroids are actually very effective for patients who have a persistent plaque of psoriasis that just doesn't clear with the topical. So you could just inject a little bit of a corticosteroid, very safe, generally well tolerated, and that could give someone relief for at least a couple of months. On the top right-hand side, I'm showing you a picture of what we call the excimer laser. This is similar to what the full body narrowband UVBs are doing, but this comes as a handheld device. So this is going to require someone to operate the device. But the nice thing here is that you could focus on certain areas and you could really ramp up the dose to make it more powerful without exposing the entire body to the UVB. Now, having said that, this could be inconvenient, this could be costly, and there aren't that many dermatology practices that actually have the excimer laser because it is expensive for us to have as well. So that is one of the limitations. So what's the best treatment for scalp psoriasis? Well, generally speaking, if a drug works well for the skin, I'm talking about a systemic therapy here now. If it works well for the skin, it's going to work well for the scalp, right? In other words, there is no medicine out there that works just for the scalp and it doesn't work good for the skin or vice versa. So they tend to track pretty well together, right? That said, there are certain biologic and oral therapies that have been studied exclusively in people with scalp psoriasis. For example, guselkumab, that's an IL-23 inhibitor, secukinumab, that's an IL-17A inhibitor, and apremilast, that's an oral PDE4 inhibitor, also known as a Tesla. They have been studied in scalp-specific populations, and because of that, it's on the prescribing label. So the advantage here is that if you have an insurance company that won't approve a biologic or a oral therapy because you don't have 10% body surface area, you can push back and say, well, this drug has been studied in scalp psoriasis. This is in the prescribing label, and that is why I should be able to get this medication approved. And that's sometimes something we'll have to do. The next special site psoriasis that we'll be talking about is the nails. And I think it's useful to kind of group them up into nail matrix psoriasis and nail bed psoriasis. So nail matrix, that's the part underneath the cuticle that makes the actual nail. So if you have the inflammation from your psoriasis at the nail matrix, that's going to change the quality and the characteristics of the nail plate. So nail pitting, where you have depressions in the nails, that's the most common presentation of nail matrix psoriasis. You could get white spots or red spots. You could get crumbling. You could get trichonychia, which means you have these really rough nails, okay? Versus nail bed psoriasis, where the pathology is underneath the nail plate, right? We call it nail bed. And that can present with splinter hemorrhages. So these are pretty much just like broken capillaries, very common in psoriasis, but we can see it for other conditions as well. You can see thickening underneath the nails, and you can see separation. We call that onycholysis. The reason it's useful to separate these out is because nail matrix psoriasis can be potentially treated with topical therapies or intralesional steroids if you inject right into the cuticle or into the matrix, whereas nail bed psoriasis is generally more challenging to treat with topicals. Now, there is a negative, I would say, perception or connotation with having nail psoriasis because oftentimes these patients are mistaken for having nail fungus, although you can absolutely have nail fungus on top of psoriasis. And in fact, it's probably more common because once the nail is abnormal from psoriasis, it makes you more susceptible to having nail fungus. But these patients are often mistaken for having or for being smokers as well. And so there are some cosmetic or aesthetic reasons why we want to treat nail psoriasis, but it's not the only reason, right? And so it's important to know that yes, 90% of patients with nail psoriasis say that it's a cosmetic handicap, as we just talked about. But up to half of nail psoriasis patients say that it interferes with their work, playing sports, physical functioning. About half of these patients said that their nail psoriasis is painful. And up to 90% of psoriasis patients will have nail involvement. So it's very common. Okay, and up to 10% of patients may just have nail involvement without any skin manifestations. But importantly, nail psoriasis is very common in our psoriatic arthritis patients. And just like we saw with the scalp, if someone has nail disease, we really have to be thinking about psoriatic arthritis because that risk is as high as 3-fold. So how do we treat nail psoriasis? So just a couple practical things first. You want to keep the nails short, so trim it back as far back as it can go because we don't want it to get hung up on something. Wear gloves when you're working with your hands. Avoid or minimize artificial nails. Polish and hardeners are okay. Stop picking at your nails and cuticles. As you said before, trauma to the skin, even if it's pretty incidental trauma, that could worsen psoriasis. And resist cleaning underneath the nails because what ends up happening is you keep on lifting the nail up more and more and more, and that could worsen the psoriasis, and that can make you more susceptible to getting a secondary infection there as well. Now, as you mentioned before, intralesional steroids can be used for nail matrix psoriasis, especially if it's just a few fingernails involved, but it's painful. right? And so oftentimes we have to do some numbing agents or some numbing sprays or like a vibratory device to distract you, but that can be helpful if a patient can tolerate the injections. There are various topicals like topical steroids, vitamin Ds, and retinoids that can be sometimes helpful too, but we got to be careful with steroids. If you use it for too long, it can actually make the distal phalanx actually resorb, and that's not good, right? And oral therapies like apremilast and methotrexate has shown some pretty positive data for the nails. And of course, biologics work as well. And in my experience, I think the IL-17 inhibitors actually have the best data for nail psoriasis, particularly ixekizumab, that's also known as Taltz. But really, all the biologics actually have pretty good data for the nails. Now, if you have bad nail disease and you have bad skin and joint disease, okay, those patients are fairly easy to treat because I'm going to probably put them on a biologic or maybe an oral therapy. But the challenge is for patients who have very limited skin disease, they don't have psoriatic arthritis, and they just have it in the nails. And at that point, you're going to have an honest conversation with your doctor about what are the risk, benefits, and cost of going onto a oral or a injectable therapy just because you have a couple of nail areas that are involved. So that's a conversation you're going to have, and it's a personal conversation. The next type of psoriasis is inverse psoriasis. And as you can see, this affects the areas that typically we don't think about with psoriasis, right? It's usually the elbows or knees, but now we're looking at like the armpits, the groin, the genitalia. And the thing that's important to know here is that because these are typically in moist and covered areas, you're not going to see that silvery scale. Oftentimes, they just look like these kind of red, sometimes eroded plaques. And they're often mistaken by non-dermatologists as being yeast infections or even heat rashes. And what often happens is that they'll receive medication from their primary care doctors that are combination steroids and antifungals. And what we see a lot is that you could run into some serious side effects if you use these steroids for long periods of time. So if you're going to use a low or medium strength steroid for a week or so, that's okay. But if you're using these combo steroid antifungal creams for long periods of time, it can really cause skin thinning. And you can see here that the skin really has that paper thin quality. It's much more red. You see those blood vessels are being much more apparent, and it can even lead to skin breakdown. And that's because the skin is already thinner in these areas, and you're much more likely to absorb these medicines, or they're going to stay in the area longer because you got skin on skin contact. So what I prefer is non-steroidal topicals for inverse psoriasis, right? And we used to only have something called tacrolimus. It goes by Protopic, which is a non-steroidal, but it burns and it stings, right, on active areas. So it wasn't my first choice, okay? But as of last year, we actually have two really exciting new non-steroidal topicals that work quite well for the inverse areas. So roflumilast, also known as Zoryve, approved last year, works great for inverse psoriasis, very elegant vehicle. And in fact, it was studied in patients with inverse psoriasis. So this is actually on the prescribing label. Tapinarof, also known as Vtama, also a great option for inverse areas. There is an actual study going on for inverse psoriasis with Vtama, but both of these options, I think, are really nice options for people who have predominant inverse psoriasis. But sometimes it may require escalation to systemic treatment as well. Genital psoriasis is considered a subtype of inverse psoriasis, and it's actually quite common. So studies have shown up to 2/3 of patients with psoriasis currently have or have had genital psoriasis. And oftentimes they don't actually know that's what it is. So unless you're asking your patients to unrobe and you look at their genital skin, okay, they actually may not realize that they have genital psoriasis. It could affect the vulva, the vagina, the penis, the scrotum. And especially for my male patients, there's often this concern that they may have a sexually transmitted illness. Just like with any type of psoriasis, it can be worsened by friction and sexual intercourse. And the treatments pretty much are what we do for inverse psoriasis. So we can use topical steroids if needed, right? But we don't want to use it for too long. We want to transition to a non-steroidal, and I prefer the ones that we just talked about, Zoryve or Vtama. And sometimes systemic treatments are necessary too. And in fact, there are two systemic therapies, both ixekizumab, that's Taltz, that's an IL-17 inhibitor, and apremilast, which is Otezla, that's an oral therapy. Both of these drugs have been studied for people who just have genital psoriasis. They did not have 10% body surface area elsewhere. So technically, you can put patients on these medications even if they just have genital psoriasis. Moving on to palmoplantar psoriasis. This could appear in many different types. Sometimes you could just have scaling, sometimes you could just have thickening, and sometimes you could have these little kind of pus-filled pockets. We call these pustules on the palms and soles. Who gets palmoplantar psoriasis? About a quarter of patients who have moderate to severe plaque psoriasis will have it also on the palms and soles. Another way to look at this, about 1 out of 5 patients that have palmoplantar psoriasis will have psoriasis elsewhere. But that also means that there are patients out there that just have it on their palms and soles, and they don't have psoriasis everywhere else, okay? That's important. It's an important distinction because that's probably a different type of psoriasis than people who have psoriasis elsewhere and they have it on the palm and soles. And we know that because treatments don't work quite as well in people who have purely palmoplantar psoriasis. And I'm going to show you a couple of examples of that. We do seem to see this more commonly in females, although certainly I see this in men as well. There's a strong predilection for smoking. And I'll tell you, I've had patients where I've thrown the whole kitchen sink at them as far as treatment options, and I cannot get them to clear until we stop smoking, okay? And so that's something really important to know. And there's also a high risk for developing psoriatic arthritis in these patients, up to a quarter of these patients. So how to treat palmoplantar psoriasis? Well, it's not easy. Okay, topicals are often impractical. Phototherapy can be effective if you're a patient and if you can find an office that has a dedicated hand-foot unit. Many practices don't have that, or if they have the excimer laser that I talked about before. Traditional immunosuppressants like cyclosporin, methotrexate, and acitretin, they actually work fairly well, not great, but there are some safety concerns with long-term usage. Retinoids, like I talked about, especially if you have more like the pustular psoriasis, they actually work quite well, but they are sometimes hard to tolerate, especially because it gets really dry. It could cause you to lose some hair. And for females, you can't take it. Otherwise, it could cause some birth defects. And biologics, and they've been incredibly effective for plaque psoriasis. We're seeing 80, maybe 90% of patients are getting to clear or almost clear. But if you take a patient who just has psoriasis on their palms and soles, biologics only work about a third of the time, which tells us this is a different condition. This is not just regular psoriasis. Palmoplantar psoriasis is probably its own animal. And so, like I said before, just because something works well for regular psoriasis, we can't assume it's going to work great for the palms and soles. And it also depends on subtype. So as I mentioned before, if you have those little pus pockets, acitretin actually works great. But if you have more thickened skin, then we're often going to be reaching more for our older therapies like methotrexate or cyclosporin. But the bottom line here is that single or monotherapy agents generally don't work that well. We are often having to combine our therapies, okay? And the point I'm trying to make here is that you need to have a little bit of patience and you have to have a little grace for your dermatologist because this is not an easy thing to treat. A lot of times it's just trial and error. You're trying to just guess what's going to work. And what I've seen actually work the best more recently, I'll be honest, is what we call the JAK inhibitors. There's a couple of oral JAK inhibitors that are approved for conditions outside of psoriasis. They work really well for palmoplantar psoriasis. And there are some studies that are being done now, and hopefully they'll give us a little bit more data in the future. So now I'm going to talk about the importance of having treat to target goals, right? Because if we can't measure something, we can't really improve it either. So the National Psoriasis Foundation did come up with what we call these treat to target goals. And what they said is that after 3 months of starting a new treatment, you should be less than 1% body surface area. That's your palm print, that's the goal. An acceptable response, however, is if you have less than 3 palm prints or you're 75% better overall. And after an additional 3 months after you recheck in with your doctor, if you're still not at treatment goal, then you can consider changing treatment. Now, at this point, if you're happy, it doesn't mean you have to change treatment, but at least it's worth having the discussion because we have so many different therapies now in psoriasis. But what happens if we're not at treatment goal? Well, now as a dermatologist, I need to decide, is this patient flaring? Or is this patient failing their therapy, right? So if a patient is flaring, I need to try to figure out what's the cause of their flare. So I want to identify potential triggers. And common ones are medications, right? Medications that we use to treat blood pressure, for example, beta blockers can worsen psoriasis. Hydroxychloroquine, which is an anti-malarial that we use to treat psoriatic arthritis, can worsen it. Lithium, withdrawal of systemic steroids. These are all examples, and these are the things I ask about in someone that's not doing well from their psoriasis. Infections. So classically, group A strep or strep throat could worsen psoriasis, but really any type of infection, even viral infections, could probably worsen psoriasis. Stress. And I'm going to actually show you in a couple slides later what the mechanism is of how stress worsens psoriasis. But what we do know is that cortisol, which is that classic stress hormone, is very pro-inflammatory, and it can activate a lot of these cytokines that are involved in psoriasis. And then we said this before, but it's worth repeating, is skin trauma, right? We call this Kevnerization. Did you have surgery somewhere? Did you have an injury from falling? Those are sometimes reasons why you have psoriasis in those areas. Now, if you're failing your therapy, these are some of the considerations that we have as dermatologists. And at the top, and I hate to say this is sometimes the most important consideration, it's the insurance coverage, right? If you have commercial insurance versus federal or state, okay, that gives us different choices. But commercial, we could get more, whereas with federal and state plans, we are somewhat restricted to the formulary. We also wanted to differentiate, are you a primary failure or a secondary failure? So what that means is that if you never got better on your drug before, we call that a primary failure. And we probably want to switch you then outside of the class. So to give you an example, if you were on Humira, which is a TNF inhibitor, and you never got better with Humira, okay, I don't think switching you to Enbrel is going to be the best option. I probably was, which is another TNF inhibitor, by the way. I'd prefer to switch you outside of the class to maybe an IL-17 or an IL-23 inhibitor. A secondary failure means you were doing well initially, let's say for the first couple of years, and then over time you lost response, okay? In those instances, it is acceptable to stay within the class. So if you were on, let's say, Cosentyx, which is an IL-17 inhibitor, and you start to lose response over time, which can happen, then switching you to Taltz is a reasonable option, or vice versa. You could go from Taltz to Cosentyx, or of course, you could switch outside of the class as well. But we also have to consider comorbidities. So if, for example, you have congestive heart failure or multiple sclerosis, I'm not going to switch you to a TNF inhibitor because there's a potential it can make it worse, right? Or if you have inflammatory bowel disease, in addition to your psoriasis, I'm going to stay away from an IL-17 inhibitor, and I'll probably favor a TNF, an IL-12/23, or even an IL-23 inhibitor, which now recently got an indication for Crohn's disease. So this is the cover out of, I believe this is Allure a couple of years ago. And the subtitle read, Skin Rashes, Bumps, or Discolorations. Your skin may be trying to tell you something important about the state of your health, so listen up. And I don't think this was the intention of the author, but I think it does bring to light the fact that many of the conditions that we treat as dermatologists, right, they are almost a window to the inside of your body. It tells us what's going on underneath the skin, and psoriasis is no exception. And so when we see a patient with psoriasis, we also need to think about this. Okay, this is our current understanding of what's going on at the molecular level of psoriasis. We see many different immune cells that are overactive, that are responding inappropriately to what we call a trigger or a dangerous signal, and it doesn't turn off. And it's releasing all these other we call cytokines that are bringing more inflammatory cells to the area. But to think that all of this inflammation is just limited to the skin or to the plaques of psoriasis, it's a little naive, because we actually know now that this inflammation is systemic. So this could affect many different organs and tissue compartments. And so to use a topical therapy for a patient that has extensive psoriasis really sometimes makes you scratch your head, because you're like, well, this is a systemic condition that requires a systemic therapy. And so I'm going to talk just briefly about some of the other comorbidities or related conditions that we see more commonly in our psoriasis patients. I'm going to start off with cardiovascular disease, because this is probably the hottest area of research now, at least for psoriasis. And a lot of this great pioneering work is actually coming out of the NIH from Dr. Nehal Mehta's lab. So I'm going to be referencing a lot of his work. So does psoriasis increase one's cardiovascular risk? And I'm going to tell you unequivocally, yes. We have hundreds of studies now that support this positive association. I'm just showing you a couple of select articles here, but yes, having psoriasis can increase your risk for having a heart attack, a stroke, amongst a few other things. And so this is a study that was published by Dr. Mehta amongst a few other authors, looking at the relationship between cardiovascular disease and psoriasis. And what we saw was that if you had severe psoriasis, so that's 10% of your body or more psoriasis, you had a 50% increased risk of dying, the most common reasons being heart attacks, cancers, infections. On average, a patient with severe psoriasis had 5 years of a shorter life expectancy. And if I could direct your attention to this graph on the right-hand side, okay, just to orient you, we're seeing on the y-axis, that's a percentage of subjects that had a cardiovascular event, like a heart attack, for example. X-axis is age. Blue line, that's the psoriasis patients. The red line, those are controls that are age matched and gender matched, okay? So the first thing I want you to see here is that patients with psoriasis are on average 5 years earlier are more likely to have a cardiovascular event. And you can see the peak shift to the left. The second thing I want to direct your attention to is what happens at the age of 40. Okay, so at the age of 40, patients with psoriasis have twice the likelihood of having a heart attack versus those who did not have psoriasis, even after you controlled for everything else. And when you look at major adverse cardiovascular events, we call that MACE, which includes heart attacks, strokes, and cardiovascular death, we're seeing a hazard ratio of 1.53. And so what that means is that patients with psoriasis have a 53% increased risk for having one of these events versus someone that does not. Okay. And so when we think about psoriasis, again, we're not thinking this is just a cosmetic disease anymore. This is truly, right, there's implications about your overall, not just quality of life, but also the quantity of life. This is a different study looking at the likelihood of dying if you have psoriasis. So if you were above that black line, you are more likely to die. If you're under that black line, you're less likely to die. And what I want you to focus on here is the green bars. Those are patients who have greater than 10% BSA. So those are the severe patients. And what we're seeing here is that you are twice as likely to die if you had psoriasis that was greater than 10%. We didn't see that hold up for patients who had less body surface area. So this begs the question then, does treatment of psoriasis impact or improve cardiovascular risk? And so we have a couple of studies to suggest that yes, it does. So this is one study looking at how anti-inflammatory therapies, particularly with TNF inhibitors, so that's a biologic, can reduce the risk of major adverse cardiovascular events. So again, that's heart attacks, strokes, and cardiovascular deaths. And I want to start with the top row here. Here we're looking at patients who are on topical therapies. That's the reference arm. And if you jump down to the row right below that, we see 1.13. So patients who took an oral therapy for psoriasis or who got phototherapy, they actually had a slightly higher risk of having a major adverse cardiovascular event, 13% higher. But look what happens if you got a TNF inhibitor. Okay, that's a biologic. That hazard ratio now is less than 1. It's 0.80. So in other words, patients who took a biologic had a 20% reduction in having a major adverse cardiac event. This is a different study looking now at the time for someone to develop the first major cardiovascular event. So y-axis is the proportion of patients who had a cardiovascular event. X-axis is time. And then the blue line of patients who are on a TNF inhibitor. The gray line is patients who are taking methotrexate. That's an oral therapy for psoriasis. And what you clearly see here is the likelihood of having a major adverse cardiovascular event was far lower with a biologic than patients who took methotrexate, right, which is also considered to be anti-inflammatory. So this is one of the first signals that there is perhaps a protective effect of using biologic therapies. And here we're looking at how the longer you're staying on a biologic, in this case a TNF inhibitor, the further it reduces your risk of having a cardiovascular event. So x-axis is the number of years you've been on a TNF inhibitor, and y-axis is a reduction in having a major adverse cardiovascular event. And you can see that nice negative correlation there. The longer you stay on a TNF inhibitor, the lower the risk of having a coronary event. Here we're looking at a PET scan now of a patient who has psoriasis on the left-hand side, and then a patient who is an age-matched gender control on the right-hand side. And some of you may be familiar with PET scans, but what we look at here is we will give patients a radioactive tracer, and it's going to get taken up in areas of higher metabolic activity. So this is why we use it to detect cancer recurrence or monitoring, but we can also use it as a way to assess inflammation. So the more inflammation you have, the more this radioactive tracer is going to be taken up, and it's going to get darker. And so when you look at the psoriasis patient, there's a couple of key areas that are lighting up. So the first is going to be the skin. That's not a surprise, but also the joints. We're also seeing it in the liver. That area is lighting up, as well as the blood vessels. You can see all those blood vessels are lighting up with the radioactive tracer. This is another PET scan. This is at the level of what we call the aortic arch. That's the big arch in our upper chest, where the major blood vessels that feed our heart and our brain is coming out of. This is a sagittal cut, or a coronal cut. I'm sorry. This is what I'm trying to say here. This is a cut this way, all right? And so we're separating the top from the bottom here. That's just to orient you. And we added a little bit of color so you could really see the inflammation. But what you can clearly see is that the control patients really don't have much inflammation, whereas a psoriasis patient, much more inflammation that is being shown here at the level of the aortic arch. So we could be pretty confident that that inflammation is going to extend upwards into the heart and into brain. And what you're seeing here on the bottom is that as your psoriasis severity gets worse from left to right, the inflammation gets worse, right, from top to bottom. And that's even after you adjust for traditional risk factors for heart disease, right, like hypertension, hyperlipidemia, weight, and diabetes. So this is another PET scan. Now this is a sagittal section. So we're cutting a patient from left to right. We're again looking at the level of the aortic arch, and that green color is corresponding to active areas of inflammation. Baseline, 1 year, when 1 year into a biologic treatment, you can see just how much of a reduction you have in that inflammation. Same patient, but this is just a different cut now, right? And you're seeing baseline versus 1 year of treatment. Just look at the amount of inflammation that goes down at the level of the aortic arch. And just furthermore, what we're seeing here is that as the psoriasis improves on the outside, so that's going from left to right, as your skin clears, we're seeing a reduction in the inflammation, right? So really, this is just some really exciting stuff here, that we're not just treating a skin condition anymore, right? We're potentially able to lower inflammation inside of our bodies, which could potentially reduce the risk of having a major adverse cardiovascular event. Now I'm going to look at the level of the blood vessel itself. We want to look at specifically the plaques that line the inside lining of the blood vessels. And so what we're showing you here is that if you take what we call the left anterior descending artery, that's the major blood artery, the blood vessel that feeds the heart, and I cut it in half, and I look down it like a pipe, I can see components of the plaques that line the artery. And what I highlighted here in red, this is pre-treatment. The red areas are what we call the necrotic unstable plaques. That's the part of the plaques that are likely to rupture and lead to a heart attack. And what you're seeing 1 year later in B is that when you treat them with the biologic, that red area really goes away, okay, and it diminishes significantly. This is from the same study, and what we're showing you is that if you use a biologic therapy, the total plaque burden decreases, as does the non-calcified plaque. That's again the part of the plaque that is more likely to rupture and cause a heart attack. So what do we do about this? Well, the recommendation now is all psoriasis patients should get screening for cardiovascular risk factors at the age of 18, and then at least every 5 years thereafter. And there are some clear goals, right, based on your blood pressure, your BMI, and your glucose, as well as your cholesterol levels, right? And that's going to also depend on your other cardiovascular risk factors. So normally, we think about starting statin therapy based on what your risk of having a coronary event in the next, let's say, 10 years is. So we could be low risk, borderline, or high risk. Okay, but if you have psoriasis, the American Heart Association now recommends that we consider psoriasis to be a risk enhancing factor. So if you're kind of borderline of starting a statin therapy, but you have psoriasis, that might tip you into starting a statin therapy. Let's move on now to psoriatic arthritis. This is the most common comorbidity we see. About a third of our patients can develop psoriatic arthritis. The vast majority of time, it's going to appear in the skin first, and then the joints after. Okay, the average time of onset is 10 years after the skin disease. And so just because you screen someone for PSA and they don't have it at the initial encounter, it doesn't mean they're not going to develop it later down the road. There are no blood tests to diagnose psoriatic arthritis. That's important because when a rheumatologist or a dermatologist orders tests, it's to rule out other causes of arthritis, including rheumatoid arthritis, lupus, etc. The imaging may or may not be helpful. So if you have very obvious psoriatic arthritis on the x-rays, that could be helpful in diagnosing, but many times it comes back very non-specific and we're not going to really find that much additional information from an x-ray. And psoriatic arthritis could present with a wide range of manifestations. It could affect your fingers, your toes. It could affect the axial spines, the neck, as well as the lower back. You could sometimes get swollen digits. We call that dactylitis or sausage digits. It could also affect where your tendons insert, so classically Achilles heel. And some patients just have a lot of pain and fatigue kind of generalized. And so I've had patients that didn't know they had psoriatic arthritis. I put them on a biologic, not for their joints, but for the skin. And then they tell me just how much more energy they have or how much less pain they have. But the reason we care about psoriatic arthritis, especially, is the potential for irreversible joint damage if it's not treated. So what we can see in this x-ray up here is that you could get some changes that are detectable even by x-ray right? Like fusion of the joints, you could get erosions or joint space narrowing. And if we don't treat this early on and aggressively enough, there is a potential that we can't undo this damage. So how do we screen for psoriatic arthritis? Well, as dermatologists, we like to use, at least for me, checklists and questionnaires just to keep things kind of efficient, but making sure I'm not missing any questions. This is what we call the pest screening questionnaire, something you can find online. All of my patients will answer this in the waiting room, and it simply asks you, have you ever had a swollen joint? Has a doctor ever told you you had arthritis? Do you have pits in your fingernails? Do you have pain in your heels? And have you ever had a finger or a toe that just swelled up for no reason, right? Like dactylitis. And if you answer 3 out of the 5 questions yes, that's when we would consider referring you to rheumatology, or at least having discussion about starting a systemic therapy. Moving on now to the psychosocial distress and the mood disorders associated with psoriasis. We know there's a very strong correlation here with mental disorders as well as psoriasis. This has been extensively published, and as you can see here, just one snippet that I cut out here, we see that patients with psoriasis have a significantly higher likelihood of having suicidal ideation, suicidal attempts, and completed suicide. And among patients with psoriasis, those who are younger and whose psoriasis is more severe are at particular risk for suicidality. We know that psoriasis could cause significant disability, and we're showing you that psoriasis can cause as much disability as many of these other medical conditions that we're familiar with. So what we're looking at here is called the SF-36. This is a scale of how we measure severity. So you can see healthy patients in the gray column. Okay, higher the number, the better. With psoriasis, we're seeing 41.2, right? These patients are just a tad bit better than someone that has congestive heart failure. And when we look at the mental component of the SF-36, we can see that patients who have psoriasis have a mental disability that is as bad as people who have chronic lung disease. I mentioned before that there is a strong correlation with depression, stress, and psoriasis. And so one explanation for that is that when you have depression and stress, it promotes inflammatory cytokines that can actually directly worsen psoriasis. But also, when you have inflammatory cytokines that are unchecked, right, uninhibited, they can actually affect the metabolism of neurotransmitters that are important for mood regulation, like serotonin and dopamine. And we actually have antidepressants that work on those particular neurotransmitters. But the good news is that we have some data to show that biologic therapies could actually reduce the likelihood of depression, even more so than patients who take oral therapies for psoriasis or light therapy. And in this study, we saw that it reduced the risk up to 24%, or if you use the biologic versus conventional systemic therapies. And so we're getting to the end here. What's the best treatment for psoriasis? Well, it's hard to compare across different trials. Everyone's a little bit different, but one useful way to compare drugs is going to be what we call network meta-analyses. And that's pretty much synthesizing all the published data that's out there and try to tweak it a little bit so it's more of an apples to apples comparison. And what I like to look at is this measure called the PASI 100. So that is looking at how many patients do I need to treat? We call that the number needed to treat before I could get someone to 100% skin clearance. And that should be the goal for our patients with psoriasis. And what you're seeing here is that there are 4 drugs that come to the top. Risankizumab, also known as Skyrizi, ixekizumab, also known as Taltz, brodalumab, also known as Siliq, and guselkumab, also known as Tremfya. You only had to treat about 2.5 patients before you could get someone to 100% skin clearance. If you compare that to maybe, let's say, etanercept, that's Enbrel, I would have to treat 25 patients before I could get a patient that's 100% clear. And with apremilast, I would have to treat over 40 patients before I could get someone to 100% clear. And so, I'm generally probably using those 4 therapies the most. But, and this is, I think, my last slide here. This is probably the most important thing is we need to have a full medical history, right, from you. So help us help you, because the presence or absence of certain comorbidities will impact the type of treatments that we can give you, right? So for example, if you have Crohn's disease, I can't give you an IL-17 inhibitor. If you have heart failure or multiple sclerosis, I can't give you a TNF inhibitor, right? Whereas if you have, let's say, psoriatic arthritis, I might prefer an IL-17 or a TNF inhibitor. So it's really important that you give your providers as much information as you can so that we can make the best decision about what's the right therapy for you. And so this is my last slide here. These are just some take-home points. First is that not all psoriasis is created equal. Special sites deserve special attention. And the severity of psoriasis is more than just the body surface area. We've shown you a number of times now that the sites also matter just as much, maybe even more. And psoriasis, it's a chronic multi-system disorder, not just in the skin, that's associated with numerous comorbidities. And we just touched on a few today, but there's even more. And optimal treatment requires us to treat psoriasis holistically. So we can't just think about the skin. We got to think about some of these other comorbidities as well. And as I just mentioned, treatment selection will depend on the presence or absence of certain comorbidities. And so with that, I thank you all so much for your time and your kind attention. I believe we have about 10 minutes or so for some Q&A.
All right. Thank you, Dr. Song, for providing such an interesting update about what to know about psoriasis from head to toe. It's now time for our Q&A session. So our first question that we'll go through is relates to biologics, which you talked about a little bit. Can you explain why some biologics don't work on some people? And how do different bodies with psoriasis react differently to biologics?
Yeah, I mean, that's a great question. That's a billion-dollar question because we just don't know why some people respond better to certain medications. What we can say is that psoriasis might look the same from the outside, but there have been numerous genetic mutations that have been identified. And so someone's psoriasis might be due more to this genetic mutation than another. And as a result, they may respond better to one medication or another. We also know that sometimes if you can't get enough of the drug in the blood, we call that the serum exposure, it may not work as well. And so who are those patients that we have a hard time getting enough drug in the blood? It's going to be patients who generally are obese. And we've seen this with all our medications, right? So patients who are heavier, let's say 250 to 300 pounds in general, the medicines just don't work quite as well, okay? And we think a part of that is that the medicines just get metabolized too quickly. The medicine gets kind of sequestered into fat. But also sometimes we call them adipocytes or the fat cells. They could also be secreting a lot of inflammatory cytokines. And then lastly, the one thing I'll comment on here is antibodies. And so there are people that just develop antibodies that fight the medicine and lower the efficacy. And that can happen very early on, or that can happen later on in the course as well. And so earlier I mentioned that we try to differentiate between primary or secondary failures. So people that get better initially with a drug and then they lose response over time, that's a secondary failure. We do think that probably is due to antibodies that are developing and that is fighting off the drug. So for those patients, we will sometimes add what we call methotrexate. It's an older medicine by itself. It's not terribly effective, but it has been shown, at least with TNF inhibitors like Humira, that it will lower some of those antibodies that are fighting off the drug. Yes, so I got a question here in the chat box about how do you accurately measure body surface area with plaque psoriasis? Yeah, that's a great question. So there's probably two different ways of doing it. So the first way is the rule of nines. And so we kind of break each body part into 9%, and then we could kind of really quickly guesstimate what the body surface area is. So what I mean by that is that the head and neck, that's about 9%. For the upper extremities, that's about 18%. The torso will be about 36%, and then the rest will be the legs. So that's the rule of nines, and you could kind of just eyeball it that way. A more accurate way, but it's going to be a little bit more time intensive, is what I explained at the very beginning. That's the palm print rule. So I'll have a patient's hand, not my hand, but the patient's hand, make a closed palm like this, and I'll take that and I'll actually literally measure how many palm prints worth of psoriasis they have. And that's not that hard to do, but it does take time. I will say though, and I didn't mention this in the talk, there's a type of psoriasis called guttate psoriasis. So you have these tiny little, almost like raindrops. When you have guttate psoriasis, it is harder to measure, and that does take a little bit more guesswork. But by and large, if you can do the palm print rule, that's a pretty accurate assessment of body surface area. So I have another question here about how I would select the best dermatologist to treat eczema and psoriasis in a 15-year-old African American, with the primary locations being the face, scalp, and top of hands and flaky face. I think any board certified dermatologist that has experience in treating inflammatory conditions will do a great job. Depending on where you're located, you could probably find some. I believe that National Psoriasis Foundation actually has a place where you could look up providers that are registered with the NPF, which tells you they have an interest in treating psoriasis, and they're going to probably be the experts in your area. There's another question getting more towards, I think, complementary medicine. So what kind of supplements could reduce inflammation and help with psoriasis? So yeah, this is an area that's becoming, there's a lot of interest in this area. And you've mentioned two of them already, turmeric and quercetin. Fish oil, we've seen in some patients can help. It's kind of general anti-inflammatory. The Mediterranean diet has been shown in some studies maybe to help with some of the psoriasis as well. There's indigo naturalis, which is a topical that could get compounded, and there's quite a few out there. And actually, if I could just put a plug in for the Integrative Dermatology Society, it's called the IDS. I'm also part of that. It's focused on combining both the best of Western medicine, but also Eastern and Southern medicine, and really just any type of complementary medicine to kind of go over the data about some of these alternative options that are, I think, complementary, not necessarily replacing some of our Western medicine. But yeah, there are quite a bit of things that are being studied now for psoriasis, and I would just say, stay tuned, because I think there are some promising data that's coming out. And I think another question here is kind of getting to what I just said about the natural complementary medicine. So yeah, we would say certain diets, anti-inflammatory diets, turmeric is certainly a possibility. Fish oil, weight loss, I think in general helps psoriasis. In fact, I've had some really tough to treat psoriasis patients where I threw everything at them. It didn't really make a dent. And then as soon as they lost some weight, they quit smoking, and they cut out alcohol, and their psoriasis got significantly better. So I think we can't minimize the impact that lifestyle has on psoriasis as well. I got another question here on home light treatment. Is it recommended? Absolutely. I would say home or just light treatment in general is underutilized. And I get it. It's an inconvenience to have to take time out of your schedule to come into the office 2 to 3 times a week. You might have to pay a copay every single time it comes in. And so actually, from a patient perspective, it could be more expensive to get light therapy than a biologic, which actually costs a lot more money. I really like home therapy. In my experience, most insurance companies want you to have tried doing it in the office first to make sure it works for you and it's well tolerated before they will cover it. But there are two companies out there that do a pretty good job of helping you, your staff, and your patients really get approved for home light therapy. The instructions are very straightforward, so it's a really nice option. So I have a question on thoughts about Humira in pregnancy. So I would say in general, all of our biologics, okay, if you went by the old pregnancy classification scheme, where it was A, B, C, D, and X, okay, X being absolutely no circumstances should you use the medicine during pregnancy, A is helpful, B is okay. We don't use that system anymore, but if you were to use it, biologics are all class B, meaning it's overall safe. We know that most biologics will transfer from the mother to the baby as well as into the breast milk, but it doesn't necessarily mean it's going to be harmful to the baby or the breast milk. And we actually have really good registry data to support that, because outside of dermatology, in rheumatology and GI, where patients have, let's say, bad Crohn's disease or rheumatoid arthritis, where they can't afford to stop their biologics, because if they were to flare, right, from the Crohn's or the RA, it could put the baby at risk. So they actually have to stay on the therapy. And when you look at the totality of the data, it really does not seem to be an increased risk for having a spontaneous abortion or a congenital malformation by staying on a biologic therapy. Now, there is one biologic, I should just clarify, that does not really transfer to the baby or get into the breast milk. And it's because there's a part of the antibody, we call that the FC portion. That's what usually binds to the placenta and gets transferred to the baby. That's missing, okay? And that medicine is called Cimzia. So Cimzia is going to be the one biologic that's actually been studied in pregnant and lactating patients, and it's shown it doesn't really transfer at all. I would also say that in psoriasis, we do see maybe about half of patients, they actually get better during their pregnancy, right? And so it's not unreasonable to stop therapy as well. We know most of the drugs, they actually transfer from mother to baby during that 3rd trimester. So if you wanted to stop the drug at the beginning of the 3rd trimester, wait for the baby to come out, and then restart it. Okay, I think that's not I think that's reasonable as well. I don't really care about babies drinking milk that has a biologic in there because they can't absorb it. There's a reason you have to inject the biologic. If you try to swallow it, like via the breast milk, it's just not going to get absorbed. Vitamin D topical sunlight helpful? Yes. So we actually do know that vitamin D can normalize the way that your skin grows. And in fact, we have medicated topicals that have vitamin D either by itself, we call that calcipotriene, or it's in combination with steroids. And there's a couple of different formulations of that. So yes, it could work. Sunlight can also work as well. I've had patients that tell me whenever they go somewhere sunny, their psoriasis gets better. But just keep in mind, sunlight, you're getting the full spectrum of light, good and bad. Whereas in our offices, right, where we're really trying to filter out the harmful UV rays and just use the portion of the light spectrum, UVB, that we know is safe and effective for psoriasis. So I also have a question about, would you combine, I'm guessing TK2, I'm guessing that's TYK2 inhibitor. So there's one called TYK2 and Cosentyx for psoriatic arthritis. So that's an off-label question that has not been studied. There might be some rheumatologists that are out there, but I have not done that. For psoriatic arthritis, that all biologics are used and ineffective, what do you recommend? I think the question is asking if you have psoriatic arthritis and you've tried a lot of different biologics and they've been effective, what do you recommend? Yeah, I can only speak to at a high level. The question I always ask for patients who have what I consider to be really resistant psoriatic arthritis is it really psoriatic arthritis that you're treating? A lot of our psoriatic arthritis patients will have other reasons why they have pain in their joints or why they're fatigued, right? A lot of times patients have degenerative disc disease, they have osteoarthritis, fibromyalgia. And so you can use whatever psoriatic arthritis drug you want, and you could treat the inflammation from psoriatic arthritis, but it doesn't do anything for some of these other causes of joint pain. And so that is something that we see quite a bit. It's not so much that the medicine isn't working for the psoriatic arthritis, it's that we're not addressing some of the other reasons someone is not feeling well. Okay? And that's kind of just a high level thought here. There are other medicines, whether it's JAK inhibitors or other biologics that are not TNF, IL-17 or IL-23 that work for the joints as well. But certainly that's a conversation you're going to have with a rheumatologist.
Well, thank you, Dr. Song, for being here today and for answering all the many questions that we had. We really appreciate your time, and it was such a wonderful and a very informative presentation. For our viewers, if you enjoyed today's webinar and would like to learn more about upcoming webinars or events, be sure to subscribe to receive notification of events. You can view this webinar along with past webinars in our watch and listen site at psoriasis.org/watch-and-listen. While there, listen to our podcast series Sound Bites to hear the latest episode, Treating Plaque Psoriasis, Finding the Right Option with dermatologist Dr. David Rossmarin. If you have additional questions about psoriasis, psoriatic arthritis, and treatment options, contact our Patient Navigation Center by phone or by email as indicated on the screen. Thank you again for attending today's webinar. Please take the evaluation survey that you'll receive by email in a couple days. Tell us what you think by providing feedback about the presentation and content. We'd love to hear how we can make our webinars better. We value and appreciate your comments. This concludes our presentation for this evening. Thanks again for joining us for today's webinar, Psoriasis, What to Know Head to Toe with Dr. Song. Thank you.
Thank you, everyone. Have a good night.